Hi, my name is Maria Lakich, and I'm going to be presenting irritable bowel syndrome. Here is a typical presentation of a patient who has IBS. A 42-year-old healthy woman presents to her physician with 3 months of lower abdominal pain, accompanied with bloating and swelling of the lower abdomen. The pain does not radiate elsewhere, such as to her back or upwards towards her thoracic cavity. It is just diffuse through her stomach. The intensity varies from day to day. She claims to have been constipated for the past 2 weeks. Defecation does relieve some of her symptoms, while food consumption worsens it, and emotional stress as well. There's no blood seen in her stools, the patient has no allergies, she has not mentioned any weight loss, and the doctor finds no structural abnormalities in her abdomen nor signs of infection. The cause of IBS is unknown, idiopathic. It is associated with intestinal mobility abnormalities and sensitivity to visceral stimuli. Motor abnormalities of the GI tract are noticeable in IBS patients, and these include increased frequency of irregular luminal contractions, prolonged transit time, and exaggerated response to cholecystokinin. The 3 classifications of IBS are IBS with predominant constipation, which is when over a quarter of the stools are hard or lumpy and less than a quarter are loose and watery. Then there is IBS with predominant diarrhea, that's more than a quarter of the stools are loose or watery, and less than a quarter are hard and lumpy. IBS with mixed bowel habits is when more than a fourth of the stools are hard or lumpy and more than a fourth can be loose or watery at the same time. Internationally, 11% of the world's population is affected with IBS. In the US, that constitutes 10 to 15% of the population, South Asia 7%, and South America 21%. The predominant age at which the symptoms arise are from 20 to 39 years, and it's rare for IBS to arise when a person is over 50 years of age. It is more common in women than in men, and this is thought to correlate with female hormones, especially because the symptoms worsen for them during the menstrual period. IBS patients live a normal lifespan, but they do have a lower quality of life due to anxiety and the symptoms that cause pain upon their body. IBS has to be diagnosed clinically since there is no biomarker for it. IBS risk factors. Having a family member who has irritable bowel syndrome increases the risk of developing it almost double, even though there's no specific genetic link. The history of sexual or domestic abuse, mostly in women, correlates with the symptom of stress, which worsens IBS symptoms. Then there's depression, gastrointestinal infection, which likely irritates the organs of the abdomen. Lower socioeconomic status, because those people don't have adequate access to health care nor medications. IBS can occur in the presence of inflammatory bowel disease, celiac disease, idiopathic bile acid diarrhea, microscopic colitis, and duodenal ulcers. It is less common in the elderly over 50 years of age, and it is not a contagious disorder. Here are some theories that attempt to explain why IBS occurs, since the pathophysiology of IBS is unknown and there are no biomarkers to test for the disease. The first one being visceral hypersensitivity, also called hyperalgesia. Distension of the rectum and gut may be caused by dysregulation of the brain-gut axis, in which the central nervous system processes gut nociceptive info. This specifically is affected by genetic changes in serotonin secreting cells, alterations in gut microbiota metabolite production, activation of the gut immune system, increased visceral sensitivity and motility, and altered motility. The second is abnormal gastrointestinal permeability, motility, and secretion. Diarrhea-type IBS has rapid colon transit times and increased intestinal permeability. Those with bloating and constipation have the exact opposite occurring. Post-inflammatory IBS is associated with intestinal infection and other low-grade infections because they disrupt the normal intestinal bacteria and the immune activation of the gut. This one is diagnosed if 2 of the following occur: fever, vomiting, diarrhea, or a positive stool culture. The next is alteration in gut microbiota. This influences sensory, motor, and immune systems of the gut and interacts with brain centers. Then there's food allergy and intolerance. Specific food antigens may activate the mucosal immune system and alter intestinal flora or mediate hypersensitivity reactions, which would not occur in a person who does not have irritable bowel syndrome. The last theory has to do with psychological factors, and it states that early life trauma, abuse, or emotional stress interact with the neuroendocrine, neuroimmune, and autonomic nervous systems, as well as pain modulators contributing to IBS symptoms. The symptoms of IBS include chronic abdominal pain, which is described as a cramping sensation with variable intensity, variable location, and is related to defecation exacerbated with emotional stress and meals. IBS causes altered bowel habits, including diarrhea, constipation, and alterations between those two. Diarrhea is described as being the frequent loose stools of varying volumes. Bowel movements generally occur during waking hours and after eating meals. Most bowel movements preceded with abdominal pain, urgency, and a sense of incomplete evacuation. Constipation is the opposite. It is when the stools are very hard, described as being pellet-shaped, and patients claim to experience tenesmus even when the rectum is empty. Before being diagnosed with IBS, patients are usually tested and further evaluated to rule out other diagnoses, especially if they complain of symptoms such as abdominal pain that awakens them from sleeping, blood in their stools, and unintended weight loss. These other diagnoses can include inflammatory bowel disease, a celiac spur, colitis, inflammation of the colon, lactose intolerance or fructose malabsorption, and infections such as Salmonella, Clostridium difficile, and a few others. The diagnosis of IBS is made if the patient claims to have had at least 3 days a month of recurrent abdominal pain or discomfort over the past 3 months, as well as 2 other symptoms that were previously mentioned, including the chronic abdominal pain and altered bowel habits that are further irritated by meals and lessened via defecation. The most common way of diagnosing IBS is using something called the Rome 4 criteria, which states that recurrent abdominal pain for at least once a week is present for 3 months with 2 of the following. It is defecation related, associated with a change in stool frequency and stool form. Other criteria include the Manning criteria, which says that a relief of pain with bowel movements is present. There is a passage of mucus, a sense of incomplete emptying, and looser stools. And then the other is the Crew criteria, which is much less frequent. And then the only purpose for lab testing in IBS is to rule out other diagnoses. Since there is no permanent cure for IBS, the main goal of treatment is to reduce symptoms and improve the quality of life of the patient as much as possible. This is first done by determining if the IBS is diarrhea or constipation prominent, and then further actions can be taken to move towards that goal. Lifestyle modifications include exercising 3 to 5 times a week to decrease the severity of the symptoms, as well as a food diary to determine triggers of the abdominal pain. Probiotics such as Lactobacillus, Bifidobacterium, and Streptococcus have proven to be beneficial, and as well as medications to improve abdominal pain, global symptoms, which are the symptoms that almost everybody with IBS has experiences, and symptom severity. These are the references that I used for my presentation. Thank you for your attention, and I hope this was helpful.